with covering about Perio and the limits. So basically, Perio and have the same embryonic origin and the infections which are related to Perio and Endo are both from anaerobic bacteria. The combined endothelial lesions are estimated to cause 50% of the mortality. So it is very important to diagnose endothelial lesions and treat them accordingly. So what are the pathways which connects endodontic with the periodontal tissues? There are anatomic pathways and there are pathological pathways. So first we'll discuss anatomical pathway which connects the endodontic with periodontal. So anatomy, how the endodontic tissues develops around the periodontal tissues. So by the dentinal tubules. Dentinal tubules which run through the cementum. They can also act as a communication between perio and endodontic tissues. Accessory canals, the lateral canals, apical foramina, the developmental canals. There are the four factors which we consider in anatomical relationship for communication which connects periodic and that is dentinal tubules, accessory and lateral root canals, apical foramina, yeah, development. So basically, the frequency of lateral canals are more in apical third, that is 17%, and at a coronal end, which is around 1.6%, and the rest of the root, it is around 8.8%. That means most of the accessory canals are present at the apical third of the tooth. And in multi-rooted teeth, it is around 50 to 60% in a population area. When you consider first molar, around 46% of first molar population have accessory canals. So, what is the pathological communication that considered with the spread of infection from pulp to periodontal tissues or periodontal disease to the pulp? So, whenever you are preparing a axis cavity, you may end up with a perforation. Those perforation act as a pathological communication between your periodontal tissue and the pulp endodontal tissue. A internal root resorption that may communicate with surrounding tissue. External root resorption also helps in communication with endodontic periodontal tissues. So these are the three factors which are considered in pathological relationship between endothelial endo, that is lateral perforation. Whenever you prepare in the excess of you are beyond the perforation area and around lateral root surfaces. Those perforations act as a communication between the endodontal tissues and periodontal tissues. And there will be a external resorption or internal resorption. So coming to dentinal tubules will create a communication between your pulp and periodontal tissue. Okay. Like whenever you do aggressive scaling, you are following root line, you expose the dentinal tubules. Yeah, in recession, yeah, gap junction between your enamels and dentinal tubules are exposed to oral fluid. So these open dentinal tubules act as a communication between the pearl and periodontal. So there is a chances of the spread of infection from periodontal tissue to pulp to periodontal tissues. So dentinal tubules divide off covering cemental layer have been suggested as a possible pathway for bacteria and anatomically affected by the periodontal tract. Even though if it is root surface is covering with the cementum layer, a few studies suggest that the pathways and communication between periodontal tissue and endodontal tissues is possible, even though there is a layer of cementum present on the root surface. So another anatomical factor which may lead to endothelial lesions is palatogingival groove. This is a developmental groove most commonly seen on your axillary, lateral, and central incisors. Central incisors. And it may contribute to spread of infection from periodontal tissues to pulp or from pulp to periodontal tissues. So it is very important to detect the palatogingival groove, do the vitality testing, check the periodontal status of that particular tooth, take a radiograph, plan treatment according to your history. So how the infection is spread from periodontal tissues to pulp. So any pathological bacteria and inflammatory products from periodontal tissue to accessory canals, that through lateral canals, that through apical foramina, spreads to pulp and causes the pulpitis, that is called as retrograde pulpitis. So this infection is going from the surrounding periodontal tissues to pulp. So there won't be any caries in such cases. So this is called as retrograde pulpitis. The infection from periodontal tissues to pulp through accessory canals, lateral root canals, and through apical foramen. So how the infection spreads from pulp to PDL. Whenever there is a pulpal inflammation or infection, the perforations or vertical fractures through dentinal tubules or through accessory canals or through apical foramen. The infection spread from pulp to surrounding periodontal tissues. In such cases, we see the bone loss, increased clinical attachment loss, and perforation. So such cases are termed as a retrograde periodontitis. Whenever the infection spreads from parental tissues to pulp, we call it as a retrograde pulpitis. It is spread from pulp to parental tissues as a retrograde primary periodontal lesions and combined. Again, it combined primary periodontal, secondary endodontic, primary endodontic, secondary periodontal, and this is the most commonly followed classification in endothelial lesions. Once again, I will repeat the classification. This is how we classify the endothelial lesions. Primary endodontic disease, primary periodontal disease, or combined disease. Again, when combined, it is a primary periodontal, secondary endodontic, primary endodontic, secondary periodontal, through combined disease. So what is primary endodontic? What is primary endodontic work? Here we see a case. So the exam properly. In a primary endodontic lesion, should be a various teeth and there should be a periapical inflammation without involving the surrounding tissues. There is no involvement of periodontal tissues, but whenever you see a clinically or radiographically, you'll see the caries of involving tooth and periapical radiolutions or periapical pathology without involvement of surrounding periodontal tissues. Such lesions are called considered under primary endodontic. So primary endodontic and secondary periodontal. So whenever there is a caries present, involvement of pulp, that is pulpitis, spread of infection from pulp to surrounding periodontal tissues through apical foramina, lateral root canals, accessory canals may spread the infection from pulp to surrounding tissues. In such cases, we'll see the decayed tooth with periapical pathology and bone loss around the involved tooth. So such conditions we term it as a primary endodontic and secondary periodontal involvement. Once again, I'll repeat. Primarily, there will be a caries involvement tooth, pulpitis, periapical pathology. So once the periapical pathology develops, the spread of infection spreads from pulp to surrounding tissue tooth. accessory root canals, lateral root canals, vital foramina spreads to surrounding periodontal tissue. So when it spreads to surrounding periodontal tissue, we see the loss of periodontal structures over that area. So such cases to be considered in a primary endo and secondary periodontal disease. So primary periodontal. So whenever patient comes to your clinic with a complaint of pain or a recurring examine clinically, they want the involvement of any carriers too, but patients still have a pain because there will be a deep pocket, a periodontal success loss around that particular tooth without involving any pulpal tissue, there won't be any carriers tooth. So such conditions are involved in a primary periodontal conditions. So there is a chances of spread of infection from surrounding tissues to dental pulp through accessory canals or through apical foramen to lateral. So in such cases, you don't see actually caries. The spread of infection is through these accessory canals, apical foramina, lateral root canals to periodontal tissue. In such cases, you will find deep periodontal pockets, bone loss, swelling around the gingiva, there may be a sinus tract presentation. So such cases should be considered as a primary periodontal and secondary endodontal lesions. So there are two combined periodontal and endodontal lesions. So the both periodontal disease and endodontal disease are started at the same particular point. In such cases, we see the severe bone loss around the involving tooth and involvement of the whole and periapical pathology. So the disease has both diseases has started at the same point of time. So lesions are included in a true combined periodontal and endodontal lesions. So clinically, what are the symptoms of how the patient with the endoperio or perio-endo present to your clinic? There may be a periodontal changes in gingival tissues, there may be a mobility, there may be an exudation present in the pocket. Whenever you tender to a patient will have a pain because of perioperative pathology. So there may be a sinus tract, a fistula tract that is present in the front. In acute cases, there may be a swelling of involved tooth. In chronic cases, there may be a sinus tract present in the particular. So these are the clinical symptoms when a patient have a perio-endo lesion. They may come to a clinic with these clinical features. That is, swelling, changes in a gingiva, that is swelling around gingiva. There may be a pocket formation, burst discharge, and mobility may be present. Whatever the purpose, it will be connected what it will under percussion. There may be a sinus tract presentation. So how the lesions are usually present. So whenever there is a primary endodontic lesions, patient will have a moderate to severe pain. There will be a decay to. If it is acute case, then there may be a swelling may be present. If it is chronic, sinus tract may be present. So whenever you grow surrounding periodontal tissue, there won't be any periodontal involved. So when you evaluate clinically, patient complaints of moderate to severe pain. There may be a swelling present in acute cases, a sinus tract in chronic cases, but there is no periodontal pocket formation or periodontal tissue loss around the particular tooth. Such lesions are to be considered in primary endodontal. So primary periodontal. So patient may have usually periodontal problems. They present to you with a dull, continuous aching pain. It won't be a severe, it is a dull, continuous aching pain. Swelling may be present around the tooth involving gingiva. Whenever it grows, the growth will have a severe periodontal pocket, a deep periodontal pockets around involved teeth. Coming to combined pulpal and periodontal lesions, patient complains to you with a moderate to severe pain. There might be a swelling, a sinus tract present. whenever you probe both periodontal and endodontal clinical features will be present in combined periodontal and endodontal lesions. So, how do you diagnose the case of endothelial lesions? First, you should record proper case history, examination, any caries teeth, the periodontal involvement. After that, you should take a radiograph. Just see in a radiograph any caries teeth and caries around the teeth. If there are any bone destructions around that. Then go with the pulp testing, electric pulp testing. We are told whatever it may be, you should do the pulp testing. Then sinus tracking means you should insert a catapuncture within the sinus tract and take a radiograph that will show you the sinus tract where it is coming from. So it is easy to diagnose. So like a visual examination you clinically do. Whenever you do a soft tissue examination around involved teeth, there may be a gingival inflammation, ulceration, bleeding on probing, and pocket present around that particular involved teeth. So whenever you examine the teeth, there may be a carious lesion, a defective restorations, cracks within the tooth, the fractures, or discoloration. So clinical features when you examine a soft tissue, there may be an inflammation as swelling around that particular. There may be ulcerations or sinus tract. Coming to teeth examination, there might be a caries, a defective restorations in volume pulp, a cracks extending tooth pulp, a fractures in volume pulp, and internal or external root resorption that may lead to discoloration. So whenever you purpose vertically, patient will have a pena vertical tendon percussion only if it involves a periapical tissue. That means if it involves a pulp, then only the vertical tendon percussion will be positive. So horizontal tendon percussion is positive. Without vertical, then there is an involvement of periodontal structures. Mm, any any endothelial lesions, the mobility will be present, like because of loss of periodontal tissues or because of periradicular or periapical abscess and fractured roots. Because of these causes, the mobility will be present in endothelial lesions. So whenever you grow, the solitary periodontal pockets are present in an endodontic cases. The solitary periodontal pockets. The pockets are broad and deep, then it is an involvement of your perio. So track the sinus with a gutta percha, take the radiograph. So as we see in a picture, through the gutta percha, through a sinus tract, it is reached into apical area of that particular tooth. When to pulp testing, electric pulp testing, we are told just. So whenever you do a pulp test, if it is a primary periodontal lesion, it will be a positive. Pulp testing will come as a positive. If it is primary periodontal and secondary endodontic, it may be a positive and it may be negative. If it is a primary endodontic lesion, again it might be a positive, it may be a negative. Primary endodontic and secondary periodontal, there won't be any response from the pulp. Combined pulpal and perio, there won't be any response from your pulp through a pulp testing. So how do you make a decision about your treatment plan? Depending on the findings, whatever you record, like taking case history, clinical examination, probing, radiograph, a pulp vitality test. So whenever your patient have periodontal pockets without involvement of pulp or periapical pathology, that means it is a true or primary periodontal lesions without involvement of any endodontic tissues. So such cases should be treated periodontally, that is scaling, root planing, if necessary, periodontal surgery can be done. So suppose if periodontal pockets are present, there may be a pulpal and periapical involvement. That means it is a case of primary, perio and secondary endo. Such cases should be treated accordingly. Root canal should be done first, followed by a periodontal treatment. The that is scaling root learning. Yeah, okay, so again coming to if your pulpal and periapical pathology is present without any periodontal involvement, there won't be any periodontal pockets. There might be a swelling, a sinus tract may be present. So in such cases indicates there is an involvement of primary endo without any periodontal structures. So such cases should be treated with the root canal treatment. If there is a presence of pulpal and periapical pathology along with deep periodontal pockets, that is primary endo and secondary perio. So such cases also be treated with a root canal and followed by periodontal treatment. If pulpal and periapical pathology is present and there will be a severe deep periodontal pockets, that means that is a case of combined perio endo. So again, it is treated with a root canal followed by periodontal treatment. So just remember, whenever you have a periodontal findings without any endodontic findings, like no caries, no pulpitis, no periapical pathology, so that is a true case of primary periodontal lesions. So such cases should be treated accordingly. That is periodontal treatment can be carried out scaling medication followed by periodontal surgery. If periodontal pockets are present along with your pulpal and periapical pathology, that is a case of primary perio and secondary endo. So such cases should be treated as first root canal and followed by periodontal treatment. So if there is an involvement of pulp and periapical pathology without periodontal pockets as sinus tract may be present and with swelling. Such cases should be considered as a primary endodontic to be treated with root canal. Pulpal and periapical pathology, both is present. Moderate pockets, that may be the case of primary endo and secondary perio. Treated with the root canal followed by periodontal treatment. Again, pulpal periapical pathology, severe periodontal pockets around that tooth. That means that is a case of combined perio endo. Treated with the root canal followed by periodontal therapy. So always the prognosis of perio-endo lesions depend on the patient's oral hygiene, the amount of attachment loss around the tooth, endodontic status, and effectiveness of your periodontal treatment. So always your primary endo have an excellent prognosis. Primary perio also have a good, fair to good prognosis. Combined lesions will have always poor prognosis, or questionable prognosis. So this is how you will treat your patient accordingly. If it is a case of primary endodontic, that means there is a various to involvement of bulk in periapical pathology without any involvement of surrounding such cases to get a root canal treatment. If it is a primary periodontal, that means there is a deep periodontal pockets without involvement of pulpal involvement. Then such cases should be treated with periodontal therapy. If it is primary endodontic and secondary periodontal, any combined lesions, primary endodontic or primary periodontal and secondary endodontic, through combined lesions, they should always be treated with a root canal treatment followed by periodontal therapy. Now, just see the screen and tell me the diagnosis. Hello. Suppose if a 42-year-old male patient presented with a complaint of acute pain and swelling in the left mandibular area, when a medical history is not contributory, periodontal examination, the periodontal property 27 and 28, vitality test is negative, radiographic examination for bone loss around the distal root of the V7. Just see this radiograph and tell me which type of lesion it is. Primary perio, primary endo, the primary perio, secondary endo, primary endo, secondary endo, a combined disease. Hello?
Primary perio, primary perio,
Primary perio and when you say periodical changes over there, so this is a case of primary, perio, and secondary endo. So what will be your treatment plan?
Scaling and then RCT.
Okay. So first we extract this P8, do a root canal treatment, followed by your periodontal surgical therapy. So again, second case, a 45-year-old female presented with the complaint of intermittent pain and periodic discharge of first from the tooth, D6, but medical history not contributory. On examination, there is a gingival bleeding, swelling around buccal side of your D6. So when a periodontal examination shows the protein depth in a percussion area was around 12 millimeter, grade 3 percussion lesion, tendon percussion, mobility is present. So this is the radio log. So what is your diagnosis? Hello.
So primary endo and secondary perio.
Yes. Hello. This is a case of primary endo and secondary perio treatment. First going endodontally, followed by your periodontal surgical treatment. So that is the case. This is a primary endo and secondary perio. After treatment of your 3 months after your antibiotic treatment, 2 year withdrawal after your periodontal treatment. There is a complete healing around. So conclusion, the proper diagnosis and complete treatment of both aspects of perioendometrium are essential for successful long-term results. If you don't treat any one lesion, it may lead to the involvement of other issues of the. Any doubts?
No, sir.
No. Hello. You can ask me if you have any doubts.